MS, MOGAD, and MOSD share a lot of similarities in their clinical presentation. One of the most common clinical presentations of MS is optic neuritis, so an acute inflammatory disease of the optic nerve that cause blurred vision, painful eye movements, and reduced color vision. And we can have something very similar in MOSD, but in MOSD it's quite often bilateral, so it affects the two eye and it is much more severe. Another typical presentation is the involvement of the spinal cord. The involvement of the spinal cord can be with motor signs, so reduced power, especially in the legs, can be with sensory symptoms, so pins and needles, or tingling in the legs, or can be with acute onset bowel and bladder dysfunction. Generally speaking, the clinical presentations in NMOSD, when there is an involvement of the spinal cord, are much more severe than MS and MOGAD. And in MOSD, we have quite often an involvement of the motor tracts, so with very severe motor symptoms. And this is generally not the case in MS, where sensory symptoms are much more common. Another key point is that based on the current evidence that we have, we don't have really asymptomatic brain lesions or spinal cord lesions in NMO and in MOGAD. While in MS, we can have asymptomatic brain and spinal cord lesions. So ideally, a person with MS can present with isolated radiological presentation, so where there are only brain lesions in the absence of typical symptoms. Overall, the differentiation is not entirely clinical. Of course, the clinical picture has to guide investigations, but the diagnosis is made of different parts. So, for instance, if there is an involvement of the optic nerve, we need to study the optic nerve using different modalities, and MRI and OCT can actually help detecting differences between MOGAD and NMOSD and MS. Brain MRI is extremely helpful and can show a lot of difference between the three diseases, and same is spinal cord MRI. Last but not least, there is CSF analysis. CSF analysis, in my opinion, remains very important in confirming the diagnosis of MS, but also in excluding other diagnoses. For instance, we have oligochronal bands and the kappa-free light chain index that can differentiate MS from NMOSD and MOGAD, where the rate of positivity of these two tests is much lower. Last but not least, there are cell-based assays for the detection of specific antibodies in aquaporin 4 for NMOSD and MOG antibodies for MOGAD. So actually the final diagnosis starts from the clinical presentation, but is made of little paraclinical tools that need to be combined as needed.